What is up, everybody? Thank you for tuning in. Today I have the honor of having Jake Harden for the third time, I think it is.
Think so.
So do you mind introducing yourself again to our listeners?
Yeah, so I'm like a recurring guest here now. That's pretty cool.
You're part of the podcast
Yeah.
now.
So my name is Jake Harden. I'm a chiropractor here in Orlando. I run Orlando Sports Rehab, with I guess rehab being kind of my forte, and also teach continuing education on the same topic. And today I am the patient.
So tell us a little bit about that. What are you
Yes.
going through? Yeah.
So for the past, I guess this was week 15, past 15 weeks, I've been dealing with sciatica. So uh, to be more specific, a S1 radiculopathy. And it's been eye opening. It's been challenging. It's been depressing. It's been a lot of things. And so we thought it'd be fun to kind of come on and one, talk about how I've been self managing it, and also just kind of a lot of the things been going through.
Definitely. We've already talked about this, but for the listeners out there, how did this start? Was it a specific
Yeah,
movement or was it cumulative? Tell us a little bit about that.
yeah. So I guess there's the things that I can go. I'll take everyone through the things that I know,
Yep.
and then I can kind of go through some more of these speculative things that I don't know, but um, where you kind of play that guessing game of how did this all happen. So I guess to kind of go a little bit further back through most of 2020, dealt with some recurrent back pain, a lot of stiffness, especially in the mornings, which is out of the ordinary for me. And then around February of this year, 2021, I the only thing I can think of was I was doing a squat. I was on my last rep of my last set, and it was coming up, and I felt the best way I can describe it is I felt like my back flexed on the way up, like without me tipping forward. Like my spine was vertical, but my back felt like it went into flexion. Um, and after doing that, I had hamstring curls after that. And so I went on my seated hamstring curl machine, and I couldn't put out any force out of my hamstring. Like, had to drop the weight way down comparative to what I normally do. Um, and it hurt, had a little bit of pain. And that day I had quite a bit of like stinging, burning back pain, kind of right around my tailbone area. And but I laid down, put my kid down for a nap, kind of laid down, got up a couple hours later, and my back was good. I had no pain. And within 2 weeks, I was back to all my normal loads, no issue. So that was February, and I have no idea if any of that prior stuff that I just said is related to what I'm going through now. I have no idea.
Gotcha.
But it's speculation. So 15 weeks ago, where I actually know. Um, so since that February event, I noticed that I was having a lot of trouble hip hinging. I would hip hinge down, um, and I feel this really sharp pull in my right glute. And not that I couldn't perform the motion, but it was there. And definitely, it was enough to get me to just switch to sumo deadlifts instead of conventional. And I was so because of that, it wasn't really limiting my life in any way, shape, or form. So I was like, I don't care. I'm just gonna let it ride. And um, got to trying to think where I was May, end of April. I don't know, April or May. It's hard for me to remember exactly where 15 weeks ago from now is. I was on deload week. I was feeling pretty beat up. Um, and I've been training hard and everything, making good progress. No real issue whatsoever, but um, it was deload week. So I was like, all right, you know what? Maybe I'll do some stuff to see if I can get my ability to hinge here. And so I knew it was kind of sciatic nerve related due to the fact that Um, whenever one, I kind of know what that pull is. Two, I know that I could elicit the same pull by doing a straight leg raise.
Gotcha.
And on that seated hamstring curl and seated leg extension, it would take me a set to like be able to really comfortably get my leg fully extended. Cause I mean, that's basically a slump
Slumps,
position,
yeah.
you know? So, um, but it would warm up and everything. But I was like, all right, this is kind of annoying me now because I want to be able to do leg extensions and ham curls. And it is stopping me from doing something there. So that was kind of like my motivation to get going with trying to do something with this. And so it's the dumbest thing. Like it's the lamest way I think to injure yourself, I guess. But I was literally doing like a sideline leg lift. Okay.
Okay.
So think like straight up laying on your side, doing that old sideline leg lift thing. But instead of having my legs out to the side, I brought my top leg over in front of me.
Okay.
Okay. So um, I'm working in that plane and I would go down just to the point I kind of felt some of that nerve tension and I'd pull out of it. Go down to the nerve tension, pull out of it. I did a few sets of that to failure, which I probably shouldn't have done.
Mm,
Um, and I knew that like, all right, I'm like, okay, my glutes are probably gonna be sore from this. This is a movement I don't normally do, yada yada, which they were. And next day I wake up, my glutes are sore, side of the hips, all that, just like I'd expect. But my right leg is really irritated,
mm,
like really irritated. And I was like having trouble walking due to that I couldn't extend my leg when I walked. I was getting a lot of pulling in my hamstring area and behind my knee and in that hip. And so I was like, oh, I think I pissed off my sciatic nerve. And it expected that, it's like, all right, well, this is probably calm down. We're just going to take it easy for a little bit, modify activities. And I did. And it didn't really, it hasn't gotten fully better yet. So we've been dealing with it.
whew. That's a long 15 weeks, dude.
It's been a
So
long 15 weeks. Yeah. So, and there's a whole lot more we'll go into, I'm sure, from there. But that is the how it started of it all.
so when did you got worried that you wanted that MRI that you got? When
Okay.
was that point where you were like, okay, I should get an MRI?
Yeah. So knowing that I was having radicular pain, kind of are the guidelines would say don't get an MRI until at least 6 weeks of it not recovering.
Mhm.
Um, I probably wouldn't have gotten an MRI at all, except for 3 weeks into it. I woke up one day and my calf was incredibly tight, which was a new symptom. And I noticed that day it hurt a lot to do any sort of plantar flexion on that right side. It felt like my calf was strained. Like it was painful to stretch it, and it was painful to put any force through it. And so with that, my calf was weak. And I assumed the weakness was due to the fact that it just hurt. And I was like, all right, well, maybe this is just a symptom of the radicular pain. I've never had radicular pain before. So maybe this is something with that. Well, the pain went away. That kind of calf strained feeling went away, but the weakness didn't. And I could not do a single leg heel rise. Like I couldn't do one rep of a single leg heel rise. I could not do a toe walk. I would get up on my toes, and the second I shifted weight to my right leg, my heel hit the ground. So I had lost all of my like resisted strength in that leg. So I would probably like if we're doing a manual muscle test on that, I'd probably grade it around a 3 because I could resist with like a little bit of manual resistance,
Okay.
and I could definitely move it against gravity and all that. Um, but I definitely had motor weakness. My little toe had gone numb, and I completely lost my Achilles
So that's a
reflex.
true radiculopathy case.
And so yes, and there now we have the radiculopathy symptoms
Yeah.
kicking in. Um, and that was the point that I was like, oh.
This is
this is
serious.
a little more serious than what I was thinking this was going to be. Um, and and it doesn't necessarily fit what I would. It didn't fit my expectations due to like there was no inciting event that I could point to, be like, oh yeah, like that
Yeah.
definitely led to something, right? So, um, I had that start around week 3, was dealing with that, and week end of week 5. So I knew I was kind of coming up on my 6-week mark. Still had the like no, I had no strength. I had no no reflex. I was like, you know what? Let's get the MRI. I know what I'm gonna see. Like I'm already ready for what I'm gonna see here. Expecting the L5S1 disc herniation. And because I was like, well, if I end up needing a neuro consult, I'm going to have the MRI to get that consult. So let's go ahead and get it. So I got it, and sure enough, there was a extremely large L5S1 paracentral disc herniation, which was pretty much fully occluding my right neural foramina, with some central encroachment as well, and kind of like shoving my thecal sac over to the left side.
That's crazy.
And um, so that was there. So I mean that it made sense then, like there's probably an inflammatory response going on. This is why we're getting a lot of these symptoms. Um, and then, yeah, but it was really the weakness. I think that was the thing that made it like, okay, wow, all right, we got to start taking this seriously.
So, how did your self management or rehab or however you want to call it start? Do you follow like this famous quote unquote rehab phases, or how did you manage that?
So for me, yeah, no real phases or anything, I would say. Um, I took inventory of every single thing that bothered me and I found was like limiting for me on day one, really. And I so I made a big list of this, put it into a spreadsheet, and like so I have this like list that says sitting on the couch, sitting up in bed, going for a walk, jogging, body weight squat, loaded squat, and the whole list. So these are kind of like all my objective markers of am I better? Am I not better? Because my progress looks like checking off all these boxes towards getting back to my life. And so early on, it was primarily stay active to tolerance. And I would say like my first 3-4 weeks of it were really a big exploratory process of exactly what can I tolerate? How active can I be? Uh, the reality of it was I think I flared myself up every Friday. Honestly, I think it was like once a week I like would do too much
Gotcha.
and re-aggravate something here and there, and it would chill out over the weekend, and I kind of figure it out again, and then something else would happen, and then I kind of settled in. But early I was really limited. Like walking was a problem because I couldn't extend my leg all the way.
Mm.
Like that's how much neural irritation there was. Then when the weakness kicked in, I started limping all over the place because I had no calf strength, so I couldn't push off on whenever I was walking. That started giving me quite a bit of Achilles issues because I was like doing this like dip down
Mm.
into my ankle all the time. It was like I was pogo hopping a mile. It felt like. Um, so and then with like exercise in the gym, which is kind of a big part of my normal routine, I took probably the first 5 weeks or so. I kind of just came to the conclusion that I'm going to have to just probably walk away from most lower body work for a little bit. And so I just went upper body only
Gotcha.
for a while. And I was okay with just letting whatever happened with the lower body happen. Um, and because I was just trying to figure it out, and I didn't want to keep kind of aggravating over and over again. And then I reintroduced some lower body work using some blood flow restriction training to just maintain muscle mass and stuff. And then I gradually started pulling in some of those lower body movements like squatting. Squatting's been the big one that I've been working on. And then more recently, some sumo deadlifting because I seem to be okay in a wider position.
And I know it's impossible to know, but if you had to guess, how long will this take for you to be 100% if you think you'll be back at 100%?
I mean, I think I'll be back at 100%. At this point, I I don't really try and predict it so as much as I just have to accept that there are certain potential timelines. Um, so right now, I accept that there's the potential that it could be a year.
Okay.
Um, like that, and if you had asked me to accept that day one, I would have looked at you like, we ain't doing that, you know. But I've made some significant progress since then, and now that it's not waking me up at night all night, every night, it's a little bit easier for me to kind of accept that. I'm hoping 3 more months
Okay.
that I feel pretty good. Um, but I guess you also have to think about what does 100% mean.
Yeah.
What is recovered is a, kind of always a big question that I like to pose to my own clients. And so, is recovered no pain, or is recovered, you know, having pain to the point that you kind of just don't care that you have pain? And I tend to lean towards that latter one for myself personally,
Hmm.
because I don't think pain's a great outcome
Yeah.
measure. And I know we had talked about this really early when this all started, but I would, there's recency bias that kind of kicks in when you start looking at pain and subjective measures like that, which, you know, if you think about your very first day, your worst day at the beginning, you might rate it as an 8 out of 10 pain or a 7 out of 10 pain. But then nowadays, 15 weeks in, I still have some days that like the pain it sits in my hip and I can't get away from it, and it's like inescapable. And when that pain's there, I'd probably rate it as a 5 or a
Okay.
6. And so, we look at our we say, like, we look at a VAS and you're like, what's the minimal valuable difference or whatever, what's a meaningful improvement? And usually it's
Yeah.
2 points.
Yeah.
So you look at that and you're like, all right, well, you would have rated this a 7 in your acute stages. Now you're saying you would rate it as a 5. So you're telling me really there's been no improvement.
Hmm. But look at
And I'm like, no, no,
everything else you
no.
can do.
There's been
Yeah.
incredible improvement. There's been incredible improvement. Um, but that's why I don't necessarily like just looking at pain as an outcome, because I have that list of objective things that bother me, and I've been checking those boxes so much. So like now I can pretty much move around and do anything I want to do except for hip hinge. I'm like, that's still really kind of off the table for me. And I can't sit and extend my leg. So hamstring curls, leg extensions, that stuff. And I knew up front that's gonna probably be the last thing that comes along. But I have I started squatting. Let's see, at week 9, I squatted an empty bar to a 18-inch box, and which is a little above parallel for me. And yesterday I squatted 170 for 10 to parallel. It was basically my normal depth. I have a kind of a low box that I'm sitting down to as kind of a safety net for myself. So I'm definitely like making progress, and that movement in particular is coming along very well. I'm probably 70, 80 pounds off of being limited more by my own strength than I am by symptoms per se. And even then, I'm not necessarily limited by symptoms right now when doing those movements. It's just kind of me taking it step by step and putting the brakes on myself so I don't overdo it. And then deadlifting, I got up to 145 this week
Okay.
on a sumo deadlift, which yeah is that's pretty far off in terms of what I've done. But I'm just being conservative with it. I'm hoping in another 3 months I feel 90% myself. Um, that would entail for me not feeling limited in most of my training, or at least to the point that I could get a good lower body workout in without having to use BFR and stuff like that. Not having trouble rolling over in bed.
Mm,
That can still be hit or miss for me. When I like push down with my leg into the bed, for some reason, sets off quite a bit of hip pain. And then I would say and then the other one would be like this resting hip pain that just sits there, and I have to use ibuprofen to get rid of it, stuff like that. I consider that kind of that is like a pain metric
mm,
that I'm looking for. Not necessarily it to be gone, but to a point that I don't notice it all the time.
gotcha. Question: did you set yourself certain parameters for your training or rehab purposes? Like, oh, if I've got a bad flare up the day after training, I'm gonna cut down volume. So tell us a little bit about those parameters if you set those.
I've been doing it pretty by feel. So I have
Okay.
some loose parameters, but I reserve the right to take a day off or modify a day or do whatever I want to do if I want to. So I do have some caps. So I'll take so for squatting and deadlifting being my two main movements that I'm rehabbing with right now, I have a cap of 6 sets that I'll do. Um, and so what I typically do is look at what weights did I use last time. I usually start about 10 pounds lower than where I ended the time before,
Okay.
10 to 15 pounds. And so with that, let's say I did 160 on Monday. So I started with 150 on uh, Thursday or Friday. Started, yeah. So Friday I did 160, and then if that feels okay, basically I got my top of my rep range, which is top would be 10. It felt okay, tolerable. I'll increase 5 pounds. That one feels tolerable. I'll increase 5 pounds, and I basically work my way up. And so I always start with something that I've done in the past because I think mentally that offers you a little bit of a confidence booster. You're not into uncharted waters from the get go. And then you have a little bit of you make a little steps of progress each time. And so I typically don't increase more than 10 to 15 pounds across a workout.
Okay.
Um, and I usually don't increase more than 20 to 25 pounds in a week from week to
Okay.
week.
Okay.
Um, I'm working each movement 3 times a week with a day in between. It was daily early on when I was like doing an empty bar,
Okay.
and stuff. It's like when you're working with 45 pounds, it's like for me, I describe it as this the difference between going for a walk and running sprints.
Mm,
You can go for a walk multiple times a day if you want to, but you probably shouldn't be running. You wouldn't run sprints
mhm.
even daily. So the more intense the exercise gets, the harder the exercise gets, the more you kind of start to spread out the frequency. So early on, I was doing a lot of just a little bit very often.
Okay.
And that allowed me to kind of close some of that early gap very soon, to where I went from like 45 to 135 pounds within 2 weeks. And then I started to slow it down a little bit as
You go heavier and
I
heavier.
started to feel it. I started to feel like I was doing something a little more. Um, Recently, Wednesdays, for whatever reason, my midday have always been a little bit more sensitive for me in the hip. not moving around as easily. And so that's usually a day that I might not try and make any progress. I might not try and get any heavier than what I've done. I might do less sets that day. I might not do anything at all that day. I just kind of play it by ear. But it, yeah, but that's kind of my loose guidelines is knowing how I'm going to progress, and then taking it day by day to decide if I should try and make that progress. But that's something I kind of like about the higher frequency of loading
Hmm.
is that if I take today off, I can make the progress next time.
Yeah,
Like I make the progress on
you'll match it.
Wednesday. I can make the progress on Friday. I'm not like I don't get one shot at this
Yeah,
week.
yeah,
To where I feel like I if I only have one shot at squatting during the week, knowing myself and my own psychology, I would be much more likely to push through something that maybe I shouldn't push through.
overdo it. Yeah. So when it comes to pain during exercise for yourself or for your patients, do you like to go, um, for example, if it's tolerable, keep going. If it's not tolerable, obviously back up instead of using numerical values, like if it's a 6 out of 10, keep going or less, whatever.
Yeah, um, I do prefer less granular options. Um, that's actually my preference in training in general. Like even with RPE,
Okay.
I don't like specific RPE targets for 90% of people because I think that it's way too granular. Um, to the point that it's not going to change your outcome. It's not going to change your decision making to shift from a 5 out of 10 pain to a 6 out of 10 pain or a 8 RPE to 7 RPE. It's probably not going to shift your decision making too much for most people. So I typically like ranges of things. And so for me, I like no pain, tolerable, edge of your tolerance,
Gotcha.
and then not tolerable. Um, Sometimes we might throw mild pain in there if we're going to do some sort of like variable loading where it's like if it was tolerable, add 5 pounds. But if it was really mild, you can add 10 pounds. But I use that less often. Usually that's whenever we have somebody who's pretty dang strong working with some high loads where, you can, the difference between 5 and 10 pounds isn't going to be
Yeah.
crazy. Um, but yeah, I personally prefer just, hey, was that tolerable to you? Because again, recency biases, right? Like five, what 5 out of 10 pain to you is going to change over time as you get anchored to new
Yeah.
things. Whatever your baseline perception becomes, you're anchored to that. And you kind of just have to ask yourself, like, hey, do you feel comfortable going and doing more than that today? Do you think that the next step forward is going to be too much for you? And that's kind of where I like that kind of like, okay, I'm at the edge of my tolerance. I just don't feel comfortable doing more than that today. Um, I think like some things like that get you less emotionally attached
Hmm.
to your physical sensations, which I think is an important thing with this. It's something I've learned, I think, through this injury specifically, given that most of the things that I've dealt with in the past have been 3 weeks max. I've never really dealt with anything that was this limiting for this long. It's an emotional roller coaster. Uh, you become emotionally attached to it, like despite your best efforts and despite everything I know and despite everything, I tell somebody, you become emotionally attached to it. And uh, trying to get some emotional disengagement from the pain, I think is useful for whenever you're trying to be a little more objective with your progressions.
So, would you say that this whole injury or rehab process did it impact a lot your mental health or the psychological part of your health, or how bad
Yeah.
was it basically?
Yeah. Ups and downs. Definitely ups and downs. There are days there have been days where I feel like a part of my identity is gone.
Gotcha.
Like when from being physical, being and having some athletic lifestyle is a part of who I am. It's been a part of who I am for the past 20 years. And so having an inability to really feel like I can go out and push myself and get my heart rate up and do something, like that makes me feel like I've lost a part of myself. Um, when it and you know and it starts to when it starts to bleed over into other areas of your life, like I feel like I can't play with my kid the same way. I feel like I'm losing a part of myself. And you know, you can deal with that when you can see some sort of light at the end of the tunnel. Like, oh, okay, if it's like 3 weeks, I can deal with this. Like, this is temporary. This will pass. And I have to keep telling myself, this is temporary. This will pass. But I have to tell myself that the timeline for this is probably longer. But the longer you deal with it, the more emotionally exhausted you become from it. And something I was thinking about the this past week was how kind of the multi-dimensional aspects of pain and all that. And one thing I think that we don't talk I need to probably talk about with patients a little more is the difference between pain intensity and pain unpleasantness.
Okay.
Um, and the way I think about it is like pain intensity is what makes you want to scream, but the unpleasantness of pain is what makes you want to just lay down and get away from it. It's what motivates you to want to get away from it, because we can have intense pain that isn't necessarily unpleasant.
Hmm.
Um, the example I would give there being like a deep tissue massage. You don't necessarily try to escape from it. You can also have low intensity pain that's very unpleasant, and that's kind of what I've been dealing with recently with my hip. So the primary symptom I deal with now at all times is this lingering feeling in my hip, like it's constantly bruised and somebody's constantly poking on that bruise. And it's always there and it's inescapable. And so, but it's not intense. It doesn't make me want to scream and, you know, like the shooting pain down my leg would. That was intense.
Gotcha.
Um, this isn't intense, but it's incredibly unpleasant to the point that I just want to go lay down and go to sleep. Like that's what it makes me want to do. I just want to go lay down and I want to go to sleep. And early on, the pain was intense and it was unpleasant, but it wasn't but I had this idea in my head that this was going to go away and this was temporary and this was going to pass very quickly. So like I dealt with that aspect of it better. And now my mental health side of this, the emotional side of this is dealing with just kind of the fact that it's very unpleasant all the time. Um, so there's been that for sure, for sure. Um, there's also been like, when did this happen too? And part of it is I say like, okay, this you almost think like this couldn't have come at a worse time, you know. And the reason I say that is like I haven't taught in a long time. So I teach continuing education. Travel's a big part of that, and due to the pandemic and everything, I haven't done that in a year or more. And so that aspect of who I am kind of has felt like it's kind of lost a
Hmm.
little bit as well. Like I've already felt like I'm kind of not I'm not living the way I want to live at the moment. And you throw this on top of it, and it's like a magnification of the stressors. On the other hand, you could say maybe this couldn't have happened at a better time, because what if I had 5 seminars on the
Yeah.
schedule next month and I couldn't go sit on a plane? It's like, would I have to cancel those, and how much stress would I be in on that front and everything else? So a lot of it's allowing the thoughts to enter your head and then reframing them and finding, talking yourself down a little bit.
Yeah, I think this is a perfect example of how pain basically affects every single aspect of the patient's or our own lives.
Absolutely.
And
Absolutely.
I know that the psychological aspect of rehab is your favorite part.
Yeah.
So how would you say that this injury has helped you, kind of like a, how do I say this? Basically, be a better clinician and help your patients with that aspect of their rehab process. Like, do you ask them certain questions, or how do you go about that?
I think it helped. I think it helps me understand more. Like it probably makes me more empathetic, if anything. Um, I think with patients that have been dealing with things for longer durations, I will be much more cognizant of just asking, "Hey, how are you getting along?" Um, because I understand right now that if I'm walking around, most of my pain limits me in situations that you would not see me in. It limits me whenever I'm trying to work out. It limits me at times when I'm trying to like roll over in bed. But otherwise I look pretty normal, you know? And so like externally I might not look like somebody who's struggling with something. And I think about that with patients that they may not look like in my office like they're struggling with something, but they might very much be struggling with something. And so it probably makes me more cognizant to ask about those sorts of things. Just like, hey man, how you getting along? Like, where's your headspace at? You know, like how is just how's it impacting your life? And that's always something I've kind of always asked is like, where are you struggling? And, you know, how's your headspace with it? But I want to be much more cognizant of kind of keeping up with those things for people. And just letting somebody be an outlet, like letting them have an outlet to just talk about it and making that a safe space to talk about it. Because whenever I personally like, I know that I think about these things. Like I know that I'm thinking about I'm aware of the fact that this is affecting me. Um, and you need like just letting, you know, having somebody to talk to about that and like letting it be out there is therapeutic. Like being on this
Yeah,
podcast is therapeutic for me to just put it out there into the world.
yeah, because you're sharing your experience.
Yeah.
So, um, how would you go about setting up expectations if it wasn't your case? Because we know that if you don't set expectations correctly, that's basically a recipe for failure when it comes to rehab. So if
Hmm.
you had a patient come in with your same case study or whatever presentation, how would you go
Hmm.
about that?
I don't know that I would go about it any differently than how I went about it with myself in reality. Um, of course, that also depends on what their narrative is in their head going through it. That's another thing. Going back to your last question, real quick, how will this help me with patients moving forward? I think it will help me to help set better expectations with people, be a little more, just be realistic with people that hey, maybe 6 weeks, maybe 8 weeks is our natural history timeline. Um, but yeah, there is a real possibility that this could last longer, and at least you don't have to necessarily be ready for that right now, but I need you to at least have it in your head that this might be there. So, if somebody were to come in and let's say I saw them, I would probably have seen them around week 3 when their calf
Yeah,
got started giving
yeah,
out on them. That's probably where I would see people walking in my office the most. So I'd ask them, "What have you been doing so far? You know, what's it been looking like so far? What have you been doing and everything? How have you been handling it?" Um, and then trying to figure out do we need to intervene here, and how much do we need to intervene? That's probably like at this point in time. Um, I kind of adhere to the thought of like if it's not broke, don't fix it. So usually, if I see somebody in their first at week 3, and they're like, "Yeah, it was pretty intense. I couldn't straighten my leg out when I was walking," and then but it's been getting better. Like that's been getting better. I would probably be pretty likely to say, why don't we just keep doing what you're doing? I mean, it's getting better. I don't know that I can speed that process up for you. We might be able to, but why change it if it's getting better? You might just be in the middle of that process. That's a phrase I use a lot.
So my question would be, I think I asked you this the other day, but when do you decide if you want to intervene with the patient, if you want to do a quote unquote rehab program?
Yeah. So, um, what's not going right? Where might we be able to improve a little bit is probably the thing we need to be looking at there. So if we are in that scenario where it's getting better, I don't think that we necessarily need to intervene per se. Then I think it becomes the patient's choice if you
Yeah.
do. Like, um, and I think that's just good informed consent, which is, hey, you could take some ibuprofen, you could see a neuro, I could give you an exercise program, I can help you, I can structure something for you. We could do this. We could see if an adjustment makes you feel better, to help bring the intensity of your symptoms down a little bit. But there's also this other real option that you could just keep doing what you're doing and naturally explore forward in terms of function. And that's an option. That's a very real option. That's an option I gave a patient this morning for something. And that's where he went with it. But what if we see somebody, and I said earlier, I think I've kind of flared this thing up. I flared this thing up a few times, or I overdid it a few times, right? So if we see somebody coming in and they're saying, yeah, it's gotten better, but I seem to, every time I try and get back into, exercising with it, I seem to make it worse. And so they're probably pushing a little bit too far into that kind of endurance coping side of thing. And so there, I think that it's more warranted that we intervene with something, at least in terms of load management and coming up with a plan of, hey, here's 3 steps for you to take to see if you can do something without flaring it up. That's what I would have done for myself, which is,
Gotcha.
all right, tell me what you've done. You've done this, and this, and it's kind of flared it up a little bit. Let's back down from that, find a baseline that doesn't flare it up, and then let's take some steps forward off of there. From that point, then we'll reevaluate if you feel like you have it and you feel like you can take it from there, or if we feel like we need to continue doing more stuff. Do you keep needing help? If in the case of the calf going weak, I because that was a new symptom, I probably would have said, let's watch that for a few weeks, see what kind of change it makes. If it's not getting better, or if it significantly gets worse, we'll get an image, and potentially a neuro consult. If that's something that you want to do, and we're open to that. And if they come in there, which I think most that's the scenario that I think we're going to see more often than not, is you're going to see somebody that's coming in that's very scared.
Yeah.
Like, I'm feeling this nerve pain. I'm getting pain down my leg. I can barely walk. Now my calf's all of a sudden gone weak and my toes numb. They're probably freaked out of their minds. And they probably already have the MRI. I'm going to guess. They've probably already seen the disc herniation. And if they have a disc herniation the size of the one I saw on my image, they're probably pretty freaked out.
Oh yeah.
So a lot of it's going to be reassurance, talking them into this disc herniation is it's likely that it's involved. We probably have an inflammatory response here. I want to get rid of the picture that I think you probably already have in your head of this thing is just like shoving your nerve up against the bone and like choke holding it.
You'll never be the same.
Let's get rid of that thought. Let's
Yeah.
get rid of that mental image right now. Get rid of jelly donut images of every time you try and bend over. But try to de-threaten the situation a little bit. Um, Figure out maybe what they're where they're apprehensive of moving forward in their life, because usually we're going to see a lot more avoidant behavior.
Yeah.
I've taken what you're hearing here with me is probably not what most people do.
Yeah.
I stayed in the gym and tried to be active and worked around it, and then gradually tried to ease my way back into normal activities. Um, which we might do. You might do that with a crick in your neck. You might do that even with a little low back strain that's kind of getting better. But I think a lot of people, whenever they get injuries like this, due to kind of our social and societal constructs around these things,
It's culture.
they they tend to be very apprehensive, worried, and avoidant in these cases. And so I'd be much more likely to, I'm going to probably intervene in that case and say, yeah, it's going to be good for me to help guide you here. One, in terms of de-escalation, and then showing you that you can move, and then helping you understand maybe what some options are for you to start engaging with aspects of your life that you might be a little apprehensive about, so that you can start moving forward.
Two questions, and I just realized that you mentioned neuro consult, and we never mentioned that you actually had a neuro consult.
Oh yeah,
You
yeah,
were considering surgery.
I was. Um, I
And
can, yeah, that's another
what
sign of progress.
what
Is how many days out of the week do I consider surgery at this point?
what did the neuro told you?
um, yeah, so I mean, the neuro said, I appreciate a couple things the neuro said, and then I don't appreciate a couple things the neuro
Hmm.
said. Um, One thing I appreciate is he told me straight up, like, if I think that you might be able to, we probably can get the pain in your leg down sooner than rehabbing it and going conservative. He's like, but if it's the weakness that is most concerning to you, which it was for me, the weakness was the reason I went into that neuro consult in the first place. He's like, I can't look you in the eye and tell you that the weakness is going to come back significantly from surgery.
Mm.
And I appreciated that. I appreciated that honesty, because that's what I needed to hear. That's why I was there. He kind of left it up to me and said, if you want surgery, we can do it. If you want to, rehab it, you can do that. And you get another image a year from now, you might see the things resorbed and it looks like it never happened. And there's that chance. And given that I have an extrusion, there's a decent chance that that'll happen. On average, like 70-ish
Hmm.
of those, 70% of those on average tend to have some level of resorption. So I appreciate all that. That was good. He kind of just said it like, when you can't, if you can't live with it, come see me. Uh, what I didn't appreciate necessarily was some of the narrative that he was giving me around why I was hurting. Um, he was, he gave me like, I want you to like think about it like your nerve is in a vice. I was like, ooh, I don't like that. I don't like
Okay.
that mental image. Um, and then he told me you know, it's bending and twisting are the things that get you into these situations. And if I were you, I don't think you should be lifting anything heavier than a gallon of
Oh, right. You
milk.
told me. I think
And
that's scary, man.
at that point, I was like, bruh,
Imagine if he
like,
tells that to a Gen Pop. They
yeah,
will.
imagine if he's not talking to me, he's
Exactly.
talking to probably the 30 other people he saw that morning with a similar situation. Because I was looking at a microdiscectomy, and that's the number one thing they perform, is what he told me. So I know that he has this
Oh
spiel
yeah.
that he's probably, giving to a lot of people. And I'm thinking, man, if I didn't know what I know, how would I be walking out of this right now? Um, of course, I can see why someone would be like, sign me up for surgery right
Mhm.
now. If I can't lift more than a gallon of milk without harming myself, without making this worse, my kid weighs 35 pounds. You know, I got to take care of
Yeah.
this right now. Um, And yeah, so that pissed me off a little bit. But um but yeah, that was neuro, mostly because of the weakness. I had done my research on the weak on kind of motor weakness and stuff. My thought was maybe taking care of it earlier might offset any long-term implications of that. In reality, the literature I looked at kind of said the outcomes look pretty similar,
long term.
and that the biggest predictor is actually the amount of strength that you have up front. So, like if you're a grade 4, then good chance it comes all back. If you're kind of less than a grade 4, it's kind of 50% chance that it comes back, but still, even then, most people improve to some degree. um, but it might not come back all the way, and that's with surgery.
Gotcha.
um,
That
and then long term between surgery and conservative looks pretty similar.
same. I'm honestly scared of referring people to surgeons, dude, because one of my mom's best friends, she had lumbar surgery. I think it was one or two horrible
Hmm.
outcomes. Then she went to the same ortho with an MRI report. It was like two herniated disc or disc bulges in the cervicals, and he recommended surgery once again. She didn't
Hmm.
try any conservative care or anything, and I'm like, I wouldn't do that.
Yeah,
It's bad. I mean, obviously, there's many reasons, maybe financial reasons or whatnot, but I think it's scary for Gen Pop.
I think absolutely. um, it's not their responsibility to know these things. They're not supposed to know. They're not supposed. As someone who is not trained in this side of healthcare, um, the only knowledge that you are even supposed to have of how pain works is through your own vicarious experiences. It's it's through every experience you've had in your past.
Yeah,
And for most people, that means I fell down, I scraped my knee, and it hurt. So pain equals damage.
yeah.
And then you throw in all sorts of societal constructs on top of that, and we got a thing. And yeah, they're not supposed to know. So we are, and we're supposed to put out a better message to them when they come to see us. I think there's a whole host of problems in terms of like a patient jumping to a specialist as the first person they see, um, with like, or a patient going to their GP and immediately getting an MRI, as part of the diagnostic triage on day one, and then getting referred to the specialist because it's like, oh, well, you got this, better go take care of it. Um, if we all just kind of followed the guidelines and
Yep.
said, hey, if the surgeon sees somebody in week 3 and they say, hey, in another 4 to 6 weeks, this might be good, and you should probably try and at least ride it out till then, because our guidelines tell us that we probably shouldn't even consider surgery before 2 months of having symptoms outside of serious medical situations. We'd probably be better off there. um and that's where it's I'm not necessarily afraid to send somebody to a surgeon, because if I've been working with them, and I'm ready to make that referral, they're probably at a point where if they decide they want it, like, it's probably at least warranted, like, that they could try that as an option.
Now that you mentioned the imaging guidelines, just for the sake of laughing, something happened at the VA this week where one of my superiors um asked me if they thought us at Palmer, if someone has pain, does that mean they should get X-rays like that? And it was a patient with cervical pain, and I'm like, do you know the Canadian C-spine rules? And she was like, the what? And I'm like, do you know the imaging guidelines? they had no idea that the something like the Canadian
Yeah,
C-spine rules exist, and I'm like,
existed.
isn't this supposed to be? Oh man, that was so stressful.
Yeah.
Um,
Oh man. Yeah. I mean, we have a lot of things we could improve upon in terms of uh, how we distribute care to people.
it'll never be perfect.
No, no, it won't. And I think that's where we have to. Things have to change on multiple levels, and primarily top down.
Yep,
We need changes in how schools teach things. We need changes at the board levels and the state association levels and all that. Um, we also, and that has to filter down to the provider too. But until then, the onus is on us as individual
yeah.
providers to keep ourselves up to date and help every single patient that we can to the best of our ability.
Love that. My last question before I let you go would be, it's not related to this. Do you have like a quote unquote favorite type of client? I know you love the psychological aspect, like, but I mean, do you prefer to work with fear avoidant behavior or the persistent copers or anything like that, or not really?
Oh, persistence copers are so much easier.
It's okay. Back down. That's it. Give me a hundred
They're so
bucks.
much easier. Um, I find that working with somebody who's more of a persistence or endurance coper, for a reference, that is somebody
Yeah,
who um, continues pushing through pain, uh, because they tend to be more motivated to continue with the other aspects of their life rather than be limited from them, and they tend to push through pain to the point that pain just continues to climb until it stops them. So they kind of go through that boom bust cycle a lot. I think that they tend to be easier to work with. It's a lot more load management, it's scale to movement, that sort of stuff. Um, yeah, working with somebody who is avoidant is much more common. They and there's different levels to that as well. I think that everyone comes in with some degree of worry. Otherwise, they probably wouldn't be coming in.
yeah.
And so there's always kind of those cognitive and emotional factors you got to deal with and you got to get through, and it's just how much of that is going on. For example, I had a older gentleman in his late 50s that was running, and we were sitting there, and he was asking about his knee, and I was asking him if he does any strength training or anything, any kind of cross training, and he was already kind of he was continuing to run, but he would feel pain when he would run, and so he would stop, and so he would kind of persist till he found pain, and then he would just kind of pull back from it. So not really avoidant, not really persistent. I'd call it more of an escape behavior style, like persist until you find it and then go away
Gotcha.
from it. Um, but he in our consult said, you know, I'm afraid to do any sort of like squatting or lunging, and he pointed over to the squat rack and he goes, if I were to go over there and do that, that would hurt my knee so bad. And I asked him, I was just like, would it? I was like, do you say that because you know that, or are you saying that because you think that it would hurt it? And he's like, oh, that's a really good question. He's like, actually, I guess I think that, I don't know, but I'm afraid to go do that. Um, and so there's a lot of reward in working with somebody who's really afraid to do something, and um, taking them through that and seeing them achieve something that they haven't been able to do for such a long time, and seeing those revelations come in their mind as well. So there's a ton of reward in working with that side of things too.
Please tell me that you got him to squat and lunge.
Oh, absolutely. Day one.
There you
Yeah.
go. There you
Yeah. So, so in his case, to finish that story, um, I told him, like, you know, we would you be okay sitting to this bench? And he's like, yeah, okay. So I had him body weight squat to the bench. The bench was a safety net. It's a kind of a term I use a lot, which is like it kind of fixes your range of motion to the point that you aren't gonna feel like you get stuck somewhere and can't get up. Um, so let him squat to the bench, and he did that. I was like, all right, now want to hold him, like, let's hold the 15-pound dumbbell as you do that. And so he did a little goblet squat, and I got him up to holding like 30, 40-pound dumbbell.
There you
And
go.
I was like, see, I was like, and the whole time we're having conversation, like, see, it's working. You can do that, right? He's like, I guess I can. And then we have him squat the empty bar. And I was like, that's good progress, man. Like, that's good for today.
Yeah.
I just wanted you to see you could do it today. And he has one of those, the tonal systems, like, wall
Yeah.
mounted workout systems. I
Yep.
was like, why don't you, like, if, would you feel comfortable, like, setting up the tonal with a chair behind you and just squatting to the chair and using that as some resistance and trying to work on, loading up your knee with that? And he's like, yeah, I think I could do that. Um, and, it's like his mindset around his knee changed
Definitely.
within 20
That's
minutes
awesome.
through some expectancy violation,
That's
you
awesome.
know? Um, and he was ready for that. He was ready to kind of find that path forward. He was very motivated to find that path forward. And we had a lot of talks about how he was going to progress his running and how we were going to get him, allowing him to run into some of the pain a little bit, but what to look out for in terms of escalation and everything. And so he was in a better place coming out of that than he was going in. So super rewarding working on that side of things a lot.
Expectancy violation. That reminds me of the predictive processing lecture that you taught at Rehab 101.
Yeah, yeah. Prediction errors.
There you go. Yeah.
You're if you're predicting that something, if you have a prediction, you have a mental construct of what's going to happen, and then so we provide some sensory information to violate that, and you update your working representation of what this is.
Yep.
Um, from a graded exposure standpoint, that's a form of inhibitory learning.
There you go. Those words make you look like 10 times smarter.
I know, right? Let's throw that out there on podcasts.
Definitely, or in a post.
Yeah,
It's been a pleasure, man, having you on again. I'm sure that people will learn a lot from this episode.
I hope so. Yeah. If you're going through it, man, just keep going through it. I guess that's my best advice. Um, if it's getting better, just keep riding it. Keep riding the wave. And um, I think that this has shown me, it's made me more human. If that makes sense. Um, showed me more the human aspect of all this. And you got to remember that it's normal to be afraid. It's normal to have thoughts of this isn't going to go away. It's normal to think that this is terrible, and from I'm sure we have some clinicians and students listening to this, and we read about these things as kind of predictors of negative outcomes. Um, but we also need to remember that it's also part of the normal kind of human experience to aversive stimuli
Yeah.
to approach things this way. And um, just as it's normal to feel that way, you also have to take a breath, take a step back, and get off the ledge a little bit too, here and there, and and then you've got to keep going,
Oh
you
yeah,
know,
it's part of life.
and somewhere along the lines you'll get better. Maybe my natural history isn't 6 weeks. Maybe my natural history is 6 months.
I wouldn't enjoy
But
that.
I'm confident it'll get there though.
You will. Where can everyone find you?
Right now,
Nowhere.
not very much. Nowhere. Um, no, I'm still hanging around Instagram quite a bit. Shoot me a DM at doctor.jacob.harden.
There you go.